Welcome to today's lecture on the topic of renal osteodystrophy. In this lecture, we will explore the intricate relationship between kidney function and bone health, focusing on the pathophysiology, diagnostic criteria, laboratory tests, treatment modalities, potential complications, and future directions in the management of renal osteodystrophy. Let us begin our discussion by understanding the normal bone metabolism and the role of kidneys in maintaining bone health. The skeletal system performs essential functions in the human body, such as providing structural support, protecting vital organs, and serving as a mineral reservoir. The process of bone metabolism involves a constant cycle of bone formation and resorption, which is tightly regulated to maintain a healthy balance. The kidneys play a crucial role in this process by regulating the levels of calcium and phosphorus in the blood. Chronic kidney disease, CKD, is a progressive condition characterized by the gradual loss of kidney function over time. It is associated with numerous metabolic disturbances, including alterations in the metabolism of minerals in bone. The pathophysiology of CKD-related bone disease involves a complex interplay of factors such as vitamin D deficiency, elevated parathyroid hormone levels, acid-base imbalances, and impaired mineral-ion homeostasis. Renal osteodystrophy encompasses a spectrum of bone abnormalities seen in patients with CKD. Several classification systems have been developed to categorize and diagnose renal osteodystrophy, including the histomorphometric classification. Diagnostic criteria involve a combination of clinical, biochemical, histological, and radiographic parameters. Maintaining an appropriate balance between calcium and phosphorus is critical for proper bone mineralization. In renal osteodystrophy, disruptions in this delicate balance occur due to impaired renal excretion of phosphorus, decreased production of active vitamin D, and elevated circulating levels of parathyroid hormone. These disturbances contribute to alterations in bone turnover and mineralization, leading to the characteristic bone abnormalities observed in renal osteodystrophy. Vitamin D plays a pivotal role in calcium homeostasis and bone health. In CKD, impaired kidney function leads to decreased activation of vitamin D, resulting in low levels of the active form, 1,25-dihydroxyvitamin D. This deficiency triggers secondary hyperparathyroidism as the parathyroid glands attempt to compensate for the reduced calcium absorption by increasing bone resorption. Consequently, bone remodeling is dysregulated, further contributing to renal osteodystrophy. Parathyroid hormone, PTH, is secreted by the parathyroid glands in response to low serum calcium levels. In CKD, the kidney's inability to excrete phosphate leads to hyperphosphatemia, suppressing the production of active vitamin D and stimulating the release of PTH. Elevated PTH levels result in bone resorption, altered mineralization, and the development of renal osteodystrophy. Histological examination of bone biopsies plays a crucial role in diagnosing and classifying renal osteodystrophy. Common histological findings include increased osteoid volume, mineralization defects, and abnormalities in bone turnover. Radiographic imaging, such as X-rays and dual-energy X-ray absorptiometry, DEXA, can reveal characteristic features like osteopenia and radiolucent or radiopaque lesions. Assessing bone metabolism in CKD patients requires a comprehensive set of laboratory tests. These tests include serum calcium, phosphorus, alkaline phosphatase, intact PTH, 25-hydroxyvitamin D, and bone turnover markers. Each parameter provides valuable information regarding mineral metabolism, bone turnover rates, and responsiveness to treatment. The management of renal osteodystrophy focuses on correcting mineral imbalances, controlling secondary hyperparathyroidism, and improving bone mineral density. Treatment strategies include the use of phosphate binders to reduce dietary absorption of phosphorus, active vitamin D analogs to overcome vitamin D deficiency, and calcimimetics to lower PTH levels. Additionally, dietary modifications and lifestyle interventions play a crucial role in managing renal osteodystrophy. Renal osteodystrophy poses several potential complications for CKD patients. The altered bone quality and mineralization defects increase the risk of fractures, leading to significant morbidity and mortality. Furthermore, disturbances in calcium and phosphate metabolism contribute to the development of vascular calcifications, which are associated with increased cardiovascular morbidity and mortality. Renal transplantation offers a significant improvement in bone health for CKD patients. Restoration of kidney function leads to enhanced activation of vitamin D, improved mineral metabolism, and decreased circulating PTH levels. Consequently, bone remodeling normalizes, contributing to the recovery of bone density and a reduced risk of fractures. Advancements in understanding renal osteodystrophy continue to drive research efforts and shape future management strategies. Ongoing studies focus on novel therapeutic agents targeting specific pathways involved in bone remodeling, optimizing treatment approaches, and developing non-invasive diagnostic tools to monitor bone health in CKD patients. In summary, renal osteodystrophy is a multifaceted condition caused by bone metabolism imbalances in CKD patients. Knowledge of its pathophysiology, diagnosis, and treatments is crucial for efficient management. Ongoing research shows promise for enhancing diagnosis, treatment, and long-term patient outcomes.